Thank you so much for inviting me to speak about this topic. It's actually nice to be kind of coming full circle from the early part of the beginning of Conference Thursday towards the latter end, still talking about the role of behavioral specialists in IBD. So if we just sort of start with a case, this is a case that I see at Mount Sinai, 34-year-old woman, 10-year history of Crohn's colitis. She's managed to her point of mucosal healing, no surgical history, but she complains of daily, persistent left lower quadrant abdominal pain, and it's now referring to her back, and so she's saying, I can't stand up straight, I can't get where I'm going. She's starting to miss work. She comes in seeking disability paperwork from her GI doctor so that she can just take the time to focus on getting rid of her pain. She's been experimenting with both cannabis and kratom, which we've heard about today, because the doctors won't appropriately give her opioids. She should not be on opioids. And she's had 4 ED visits in the last 6 months for breakthrough pain. So you might ask, if she's in mucosal healing, if her IBD is managed, why is it important for us to worry about this abdominal pain that she has? If we look more broadly, chronic pain is actually the most costly medical condition in the United States, costing about $600 billion annually. And if you compare that to a lot of our other diseases, cardiovascular disease, cancer, diabetes, they don't even come close to that. And so just from a health systems perspective, chronic pain is something that we really need to be able to deal with. But probably more on the local level or on the personal level, chronic pain behaviors are really disruptive to the IBD care team. And this is a slide from the Rome Foundation, sort of talking about patients who have centrally mediated abdominal pain and all the different ways they interfere with their medical care. So expressing their pain in a variety of ways. That first picture, she's guarding herself, she's groaning. Urgent reporting of intense symptoms. So, your nurses are getting these calls. I'm in so much pain. I think I'm going to die. I'm going to go to the ER. Patients with chronic pain are really tricky in that they often minimize the potential role of psychosocial factors influencing their pain. And so that makes it also really hard and frustrating for us to be able to get them into the proper pain management programs. Patients who are in pain end up getting way more diagnostic testing than they should, exposure to radiology and other types of things. They seek a lot of health care. And when patients are in pain and chronically pain and they feel like they're not being managed, they tend to put a lot of pressure on their GI doctors to take care of them or to get rid of the pain and to make it go away. And that really becomes a problem in the doctor-patient relationship. Now, obviously, I think we're all pretty good about not prescribing opiates for chronic pain patients, but, Dr. Sikathy is going to talk a little bit about what to do if you inherit somebody on opiates, but you will see patients putting that pressure on our team. So all of those are reasons that we should care about it, but perhaps one of the most important reasons that we should care about chronic pain in our IBD patients is that pain is actually a modifiable experience. And, we cannot have pain if it is not experienced in the brain. And so therefore, there are several things that we can do that I'm going to talk about today that really can downregulate the experience of pain in the brain and help patients do a lot better job managing that pain. Do we take the pain away? Sometimes, but usually with chronic pain, it's more about teaching patients to cope and set up their environments to be conducive to living with chronic pain. So there are several different models of chronic pain, but one that I think is particularly fitting in our IBD patient population is the fear avoidance model. And so basically that is that patients really kind of have this option when they have input of pain, whether that's because they have fullness in their stomach, they have a bowel movement waiting to come out, whether they just have chronic pain from scar tissue or from surgical procedures. Those pains can create a signal to the brain that there is something threatening or something wrong going on. Now, depending on how a patient approaches that scenario, will really determine whether or not they go on to experience some of this disability, depression, substance abuse that goes on with pain. And so I'm going to talk briefly about 2 or 3 different constructs that really you'll see in your patients, but that are also the things that are targeted for treatment for this. Now, obviously, on the right side of the slide, that's what we want to get patients to be able to take that input from the brain, say, you know what, I know what this pain is. This is scar tissue pain, this is bowel movement pain, this is my functional IBS pain on top of my, I know that my mucosa is healed. I know that this pain is not informative. This pain is not threatening. I can confront it and move on and push myself towards living a, happy, healthy life with this pain because it's just a false alarm, versus the patient who sort of becomes overly focused on the perceived threat of that. And that we call attentional bias and pain hypervigilance. And basically that is the preferential processing of threatening information. So patients will tell you they wake up in the morning, the first thing they do is they scan their body to see if there's any pain that day, and they sort of relate how their day's going to go based on how their stomach feels. Patients with chronic pain really have shown differences at the level of the brain in terms of how easily they are distracted by pain, or how much attention that they're able to pay to their pain compared to people who don't have chronic pain. So there's definitely something going on that modifying a patient's attention to their bodily sensations can be pretty helpful. Okay, pain catastrophizing is the other major contributor to the amplification of pain. And when patients catastrophize, they actually prohibit themselves from being able to emit many of their endogenous opiates, or the things that would help them downregulate the pain in the brain. So if you think about that fear avoidance model here, the first step in pain catastrophizing is the belief that the pain is serious and threatening, right? So this bowel movement that I'm about to have that's causing me pain is actually something that I should be afraid of, that's scary. Combined with the sense of helplessness, the sense that there's nothing that the patient can do about that pain, right? So that's when you get the phone call, because I have this pain, I don't know what to do about it, now it's your problem, doctor, right? And that they have no belief in themselves to be able to manage it. And because if you hold those 2 beliefs, if you hold that the pain is serious and threatening and you're afraid of it, and you have limited confidence to deal with it, then that is going to, of course, make you want to avoid it, right? Because why do you want to deal with that? That's when patients start to want to be using the opioids, using the cannabis, using the kratom, and those types of things to really avoid the disability. We know that amplification of pain occurs in this when patients view that as fearful. And I'm going to skip this next one here because I kind of just went over that. But if we think about, so the good news is that because we know attentional bias and catastrophizing are core components of the way patients experience pain, we can really leverage some of our behavioral techniques to ramp that up. So we can modify arousal, we can reduce avoidance, we can improve self-confidence, we can teach patients to decatastrophize. Hypnosis is one of the best strategies for chronic pain because it both offsets the input that goes into the brain from the perception or the attention that patients pay to that, as well as allows a more deeper change at the cognitive level around the unpleasantness or intensity of the pain. Cognitive behavior therapy, this is a slide actually from the Pittsburgh group sort of demonstrating the model of cognitive behavior therapy for IBD pain. You're changing their thoughts, you're changing their behaviors, you're keeping them from avoiding things. common issues like acceptance and mindfulness are also part of that process. And then finally, I just wanted to show a quick slide showing that if you teach patients to decatastrophize to improve their self-efficacy, reduce their fear, you actually see changes in their brains. This is a study of patients with chronic pain who have been able to increase their gray matter, or the parts of their brain that allow them to regulate the emotion and the experience of pain, just by participating in a cognitive behavior therapy program. So I'll summarize that early effective pain management is critical, and that the fear avoidance model often is a really great way to engage your patients.
All right, so let's move on to if we need to use medication. So let's go back to our case. Use of SSRIs really work best if you have comorbid anxiety or depression, which you're now going to screen for in some way. SSRIs don't seem to directly modulate GI pain. The tricyclics are first line when really the pain is the dominant issue, and you can go at relatively low doses and have a pretty good therapeutic effect. The tetracyclic antidepressants actually can help if there's a nausea vomiting component, and often can be helpful if insomnia is also an additional symptom with the pain. And the SNRIs are actually useful. Actually, any of these medications that have a noradrenergic component really have been shown to directly modulate the pain signal, and those can be helpful for patients who can't tolerate tricyclics. And this diagram is from a task force from the Rome 4 Foundation, and it'll be coming out in publication in the next several months. Now, when you don't have an effective therapeutic response, the first thing you want to do is check that you have really pushed to a therapeutic dose. Really, a therapeutic dose for these medications is either a significant reduction in pain, or the comorbid anxiety, depression, insomnia, or intolerance of side effects. We'll talk about side effects next. Then we move to augmentation strategies. So if you have really pushed the dose and you have monitored for an adequate amount of time, which can be 3 to 6 months with some of these agents, now we have a list of different kinds of augmentation agents there, and all of this we supplement with behavioral therapy. So we really also, from the psychiatric side, send the strong message that these are complementary and not alternative agents to your behavioral techniques to help you have a different relationship with your pain. In terms of the side effects, the good news for our antidepressants is they don't tend to have serious, certainly life-threatening side effects. All of them have a warning for suicidality, but later studies really went through and showed that suicidality was more linked to the severity of underlying psychiatric disease and not directly causal from these agents. For SSRIs, you may hear of GI bleeding, and there have been some case series and some meta-analyses showing a very small signal. Where you want to look at that signal is if you have other risk factors for increased bleeding, such as patients being on NSAIDs or having some other reason why they would have a higher propensity to bleed. For that reason, as well as absorption, we don't usually start any of these medications, but especially not an SSRI, for patients that are having really extremely severely active IBD, especially if it involves bleeding. Our mood stabilizers have some more what I'd call serious side effects and more disturbing to our patients, dizziness and sedation. As we move on to our atypical antipsychotics, most of them have sedation. They all have some risk of a metabolic syndrome, including increased BMI, and they're less than our typical antipsychotics, but there is some risk for extrapyramidal side effects, so unwanted movements. So in terms of pharmacological strategies now, remember we're treating pain or any of the comorbid anxiety, depression, insomnia that come along with it, one medication at a time. really starting with a pediatric dose first. Often that's responsive, and even if it's a placebo response you capture initially, we use that to our advantage. We titrate slowly, and remember that side effects are going to happen before you see therapeutic effects, sometimes separated by weeks to months, and so we have to tell our patients this so their expectancy is realistic. And monitor these agents. So often I've seen medical specialists start these medications and then monitor them when the patient happens to come back 6 months or a year later for their visit. You really want to check in or at least have a phone call out to these patients at least every 3 months until you feel like you either think that it's a therapeutic response or you decide that you're going to change. Last but not least, in terms of medication, a lot of different things influence how a patient responds really to any medication. That's including our IBD meds. How much placebo versus nocebo response they're going to have. And again, these are traits intrinsic to the patient, things like personality traits. These are things about how patients are viewing the medication or the pain, its expectancy, and so it really is important to understand what your patient's relationship is with the medication and the contextual factors that again are modifiable in many cases that help them have a better response. Cannabis we've heard about, so again, I think it's important because many of our patients, now that opioids are being much more controlled, are coming to us with cannabis, and many of them actually are reporting to us that they are finding it helpful for pain, diarrhea, and weight gain and appetite. So again, patient perception is a big driver, and this is the cannabis that they're getting themselves. You heard about the study, so again, I think just to reiterate, they're small, low-quality studies. They really don't support efficacy the same way that our FDA trials would allow us to, and even for some of our synthetic agents, there's some small studies with dronabinol showing some possible positive effects on some of the GI symptoms and for nausea, quality of life, but again, we don't have really a collection of evidence that can allow us to safely tell our patients that, yep, we definitely think this is a good idea. You heard about some of the side effects. I think the neurological and the psychological ones I think are the most disturbing, but there is some increased risk of stroke, some increased risk of cancer. Some of this is confounded with the smoking and either the concomitant tobacco use or again, the smoking itself being related to some of this risk, but there is risk. And again, cannabis is not FDA approved, and you really have to know what your state legislatures are and the legality, as you heard, it is not federally legal. Most employers who have a no drug tolerance policy, if you test positive, even with your little medicinal card, you can still be terminated for that cause. To date, there hasn't been a successful legal case of a patient winning against an employer with that policy. So I think there's things that we really just need to make sure that our patients that choose to be consumers of cannabis are educated consumers. So legal does not equal safe, legal does not equal effective, and a wide therapeutic index does not equal benign. So how many of you have had patients that have asked you about kratom? Okay, a few hands. Expect to hear about it. It's one of the most rapidly, increasingly used herbs. You can buy it mail order right now. It's not regulated. The active ingredient is a weak opioid, and patients, and this hasn't been looked at in IBD, we have several patients in the last couple of months that have come with us actually severely addicted. This is very addictive, and patients are using it to treat opioid withdrawal, mood disorders, and chronic pain. The DEA is investigating it more formally. Right now, their statement about it is it's harmful and dangerous. So you'll likely be hearing about it. So last but not least, in the last few minutes, talking about what do you do when your patients are coming to you on opioids. I think, in a general way, we want to get our patients off opioids or at least on the lowest possible dose of opioids. And we do that with a gradual taper and mindfulness to their side effects. So using things like clonidine or a benzodiazepine carefully to treat some of the possible withdrawal symptoms and really monitoring them more closely. We want to identify if they're using their opioids appropriately or if they have addiction. And I think with all of our chronic pain patients, but especially those that are also on opioids, we really need a multidisciplinary approach to the team, and we really need to max out some of those non-opioid alternative medications. Again, limited evidence for chronic syndromes, and really no strong efficacy studies for the long-term use of opioids in chronic pain. And a lot of problems. I think by now we're all getting sort of hammered by the physical dependence, the addiction, overdose, death, and infection risk increasing, the development of tolerance, and then opioid-induced hyperalgesia. I mean, these are still the thing that's happening in Pennsylvania, unfortunately, as we're regulating and having the monitoring of the opioids, the prescribed opioids across the state, are more patients actually are turning to street heroin. So I think there's still a long way that we have to go in curbing this problem. Also, opioids have GI side effects, so there are many things that they can induce, and some of these we might treat with medications, but I really try to work with the patients to use these as reasons to get them to a lower dose. If patients are on opioids, these are the considerations, so reasons why patients get in trouble with opioids. If they have central pain syndromes or multiple pain syndromes, if they have psychiatric comorbidities, obviously we don't want our pregnant patients on this, substance abuse, childhood trauma. Again, we want to look at what their disability status is, criminal history, very high doses, and aberrant behaviors are seeking opioids before they're due, and I'm going to all sorts of extremes to do so. If patients are on opioids, or if you are prescribing opioids, you really need to know your state regulations. You should be doing random tox screens, and all of this should be in at least a verbal, if not written, agreement with your patient. That's really important, and you really need that legally as well. If your patient were to end up in a malpractice suit, you want to communicate with the PCPs and pharmacies, and now some of the mandatory registries are making that easier, and you really want to make sure you have ongoing review that the benefit is outweighing the risk. Benzodiazepines are now a black box warning, so you really need to educate your patient that the side effects, including dangerous ones, can be synergistic, and think about using some kind of risk assessment instrument. Multiple are available, even especially in your patients where you're having some concern. So the last case, back to our case, we want to screen this 34-year-old for depression, anxiety, substance misuse, also adversity and trauma. And we want to start with those behavioral strategies that you heard about. And then we want to decide, again, is it pain alone or comorbid anxiety, depression to drive our pharmacological strategy with her, educating her about her cannabis use and kratom and her risks associated, and she's not on opioids, so we're going to try to keep it that way. And again, opioids in GI conditions and IBD can be indicated for sort of extreme pain, obstruction, or post-op, but really for weeks and not months. And again, anything greater than 3 months is considered chronic. So thank you.